This is Eric Strong again, and I will be talking to you today about how to identify simple acid-base disorders. Here are the learning objectives of this lecture. First, to understand the difference between acidemia and an acidosis, and between alkalemia and an alkalosis. Second, to know the four basic categories of acid-base disorders. And the last, to be able to identify simple acid-base disorders. I'll start with the frequently misused terms acidemia and acidosis and alkalemia and alkalosis. The words acidemia and alkalemia refer to a physiologic state dependent solely upon arterial pH. Acidemia is present if the pH is less than 7.35, while alkalemia is present if the pH is greater than 7.45. Acidosis and alkalosis, on the other hand, refer to the individual processes which tend to drive the pH towards acidemia and alkalemia respectively. A patient can be acidemic or alkalemic, but not both. However, a patient can have one or more acidosis and one or more alkalosis, which can directly offset one another. In some cases, this may even result in an overall normal pH. Now I will discuss the four basic categories of acid-base disorders, which you may have already inferred from the last lecture. Disorders can be either respiratory or metabolic. Respiratory disorders are those pathologic processes which disrupt acid-base balance due to their effect on the lungs. Specifically, these disorders alter alveolar ventilation. A respiratory acidosis occurs when the pCO2 is too high, that is, the patient is hypoventilating. A respiratory alkalosis occurs when the pCO2 is too low, that is, the patient is hyperventilating. Metabolic disorders are those pathologic processes which disrupt acid-base balance due to their effects on anything other than the lungs. This almost always refers to the kidneys, GI tract, or cellular respiration in general. A metabolic acidosis is present when the serum bicarbonate concentration is too low. A metabolic alkalosis is present when the bicarb is too high. This chart will need to become second nature to you before you are able to master ABGs. You may remember back to the first lecture on this series on the ABG that the five primary values given by the ABG are as follows: the pH, the PaCO2, the PaO2, the bicarbonate concentration, and the O2 saturation. Since we are talking just about the acid-base status for now, we will set aside the PaO2 and the O2 sat and just focus on the remaining three values. A quick note about the PaCO2: there is a distinction between P(a)CO2 and P(a)CO2, just like there is a distinction between P(aO2) and P(a)O2. When the A is lowercase, it is referring to the partial pressure of the relevant gas in arterial blood. When the A is uppercase, it is referring to the partial pressure of the relevant gas in the alveolar space. This distinction will be much more important when we talk about a patient's oxygenation status in future lectures. In common usage, however, if someone simply states pCO2 without specifying little or big A, it is assumed to be little a, that is, the partial pressure of carbon dioxide in arterial blood. I will frequently use this shortcut in the remaining lectures. Another quick word about notation concerns the serum bicarbonate level. You may encounter square brackets around the bicarb level like this, and I will intermittently use them during this course. The brackets denote that we are talking about the concentration of bicarbonate ion. These are frequently neglected in informal discussions, and even when I leave them out, I will still be referring to the bicarb concentration in serum unless otherwise specified. So let's get started with actually analyzing the ABG. Now this may seem obvious, but the first step to analyzing the acid-base status of a patient is always to start with the pH. If the pH is less than 7.35, the patient has acidemia and at least one acidosis. whereas if the pH is greater than 7.45, the patient has alkalemia and at least one alkalosis. Let's look at a quick example. Here, the pH is 7.25. As this is less than 7.35, this patient has an acidemia. That's very straightforward. Next is step 2, check the pCO2. If the pCO2 is deranged in the same direction as the pH, the acid-base disorder is metabolic in origin. If the pCO2 is deranged in the opposite direction as the pH, the acid-base disorder is respiratory in origin. With this example, the pCO2 is 60. This is higher than the normal pCO2 of 40. Since the pH and the pCO2 are deranged in opposite directions, the disorder present is respiratory. Thus, this patient has a respiratory acidosis. That is, the patient has a pathologic process of the respiratory system that is driving the pH to be lower than normal. Let's take a quick look at 3 more examples. In example 1, we have a patient with a pH of 7.50, a pCO2 of 45, and a bicarb of 34. Step 1, look at the pH. 7.50 is greater than 7.45, thus there is an alkalemia. Step 2, look at the pCO2. Both the pH and the pCO2 are higher than normal. Therefore, the disorder is metabolic. That is, this patient has a metabolic alkalosis. Here is example 2. pH is 7.16, pCO2 is 35, and bicarb is 12. Step 1, the pH is low. Therefore, the patient has an acidemia. Step 2, the pCO2 is also low, the same direction as the pH. Therefore, the disorder is metabolic, and we have a metabolic acidosis. Here's the final example. First, the pH is very low, so there is an acidemia. While the pH is lower than normal, the pCO2 is higher than normal. Therefore, the causative disorder is respiratory. Therefore, the patient has a respiratory acidosis. Identifying simple acid-base disorders really is that simple. In the next lecture, I'll discuss further the phenomenon of compensation and how that allows us to identify the presence of more than one acid-base disorder simultaneously.